You suspect that they got a GI bleed going, treatment.
Blood transfusion.
Well, treatment would be transport to somebody that can do something for that lower GI bleed.
Right, so do you want to give this person a NEP treatment? You want to give them oxygen?
IV, fluid, maintaining blood pressure.
So the big thing with this is, as paramedics, being those thinking paramedics and recognizing what it is that is causing the shortness of breath. You will get people, paramedics, that walk in and somebody is having a hard time breathing and immediately go to respiratory distress and boom, this person needs oxygen, I need to get their lungs opened up, and immediately assume that it's lung-related shortness of breath, right? And that is just based on lack of experience. And so this is where, before you do treatment, get the whole story, all right? You guys are the investigators here. All right, so low oxygen partial pressure in the atmosphere. Yes?
I'm sorry. So they're in respiratory, they're having difficulty breathing. Wouldn't you do your treatment to correct their breathing issue? And then you can,
But you're
You
saying.
gotta know why though. You gotta know what that breathing issue is, right? Just because somebody's breathing fast doesn't mean that they're having oxygen level issues. They can have anxiety, they can be hyperventilating, they can have a multitude of different things. What you don't wanna do is you don't wanna just roll in and be like, boom, this person's having a hard time breathing. It looks like they're having a hard time breathing. I'm gonna give them oxygen and we're gonna go from there. Right? So you wanna figure out, you wanna try, and this is where you guys will start to learn to multitask as, when you walk in, you can tell if somebody's legitimately, okay, this is a COPD, this is a CHF type patient. You'll be able to recognize that, but until you guys can recognize those things, you gotta start at the beginning and figure out what's going on, right? It's like, if I walk in and I hear somebody going, it's like, oh, yeah, okay. I can hear the wheezes from here to there. I know it's either COPD or CHF, or some sort of allergic reaction, right? All of those, do those require oxygen and immediate treatment? Absolutely. But if I walk in and somebody's just sitting there just having a hard time, I can't breathe, I can't catch my breath, or as in most anemic patients are, they're just like, you know, I just can't really catch my breath. So it's obvious that they have a little bit, they're having some shortness of breath. They're not struggling, they're not dying right there in front of you. And you're like, okay, yep, I can see something's going on. Let's figure out what's going on. Is this, do you have anxiety? Like, a lot of these things is you've got to get the history, look at the meds, try and figure out, okay, why are you short of breath? Before you just immediately just roll in and just be like, we're going to intubate this patient immediately, go. Right? So that's the thing I can't stress enough is getting your picture and figuring out before you start a treatment. Because when we start scenarios, I am like the master of scenario manipulation based on the decisions you make. Like, you will never, well, you may win. That was the funniest thing last year. It's like, people always would come to my scenarios in an attempt to win. And it's like, I could spin a scenario sideways just like this if you forget one simple little thing. I'm like, oh, all right, we just went from an SVT patient to now a patient that's overdosed because of the fact that you didn't check this, this, or this. And it's like, oh, and now they check that, I'm like, oh, and now we're back over here. Actually, the patient's a diabetic too on top of that. Just not into that at you because you didn't check the blood sugar. And so those are the types of things where you have to get the whole picture before you start your treatment plan. Okay? So does that answer your question in a roundabout way?
sure.
Perfect.
What are we doing for our patient with low hemoglobin?
There is not a whole lot we can do. The recognition of knowing that, no, this patient does not need to have a NEP treatment, no, this person does not need to be bagged, no, this person does not need immediate respiratory solumetrol. It's the recognition of what the cause of the respiratory distress is and knowing not to treat it the wrong way. And that they are going to need.
We're cross-referencing our SpO2 with our end-tidal CO2. Help us diagnose that?
Yes, yeah, but the majority of what's going to help you is going to be the history-related stuff. And like I said the last time, it was like your history will tell you virtually everything you're going to need to know. It's very rare that something in the history doesn't lead you in the direction that you should be heading. All right, low oxygen partial pressures in the air, such as,
Elevation?
okay, elevation. What other things take the place of oxygen?
Carbon monoxide.
Carbon monoxide,
Nitrogen.
Nitrogen.
when somebody comes out of a enclosed area that had an explosion in it,
Carbon.
cyanide,
Cyanide.
okay? So things that are going to lower the affinity for oxygen to bind, right? So you got your cyanide, you got carbon monoxide, so you got multiple different things, and that's just, once again, getting back to the history, recognizing these people need oxygen.
Yes, but,
Is it gonna help?
well,
It might help a
Well,
little.
It might, if the gas is trapped in their lungs, you'll force the gas out.
So, so it's very rare that the gas will get trapped in the lungs. Where does it get trapped?
In the alveoli?
And,
Or
In
in the
front.
hemoglobin?
So,
Hemoglobin?
there we go. Somebody said hemoglobin, right? So you have the affinity, right? So carbon monoxide and cyanide have like a 250 times greater affinity to bind over oxygen, right? So that's why if you try and overload the system with oxygen, as the exchange of gases are occurring, you're trying to take the place of every cyanide and carbon dioxide that gets offloaded, right? So you're trying to overload, you're trying to flush out. So with these patients, it's actually okay to give these, I mean, obviously, you're gonna give them oxygen, but you're actually accomplishing something when you're giving the oxygen to these patients, okay? So obviously remove them from the area, don't go rushing in. And so I got a good story about rushing in and all that kind of good stuff with that one, so. So yeah, don't rush in, get them out of the atmosphere they're in, clean air, lots of oxygen, and move on. Pneumos and hemos, what does this affect?
Well,
Pressure.
The ability to.
Pressure,
to-
volume.
Volume of pressure, the
Prevents-
volume, the mechanical aspect of ventilation, the gas exchange. What do we do for pneumothoraxes?
Needle
Needle
decompression.
crack, or needle decompression.
Well, we
See,
just
you get,
find it first.
man, what do we do for pneumothoraxes?
Decompression.
We get the whole story first, right? Right?
Right.
Right? So do we immediately jump to needle decompressing the pneumothorax? No, not at all, because there's a lot of different things. The only pneumothoraxes that we ever decompress are tension
Tension.
pneumothoraxes. A regular pneumo, we don't decompress, right? And that will fail you on the national exam, just so you know. In trauma-related scenarios, if you decompress a non-tension pneumothorax, or, yes, if you decompress a regular pneumo, that's a fail a lot of times, so. A pneumo versus tension pneumo, okay? The pneumo is simply a collapse of one lung, yes?
Yes.
Everybody agree?
Yeah.
Boom, so you collapse one lung. Most common to happen in what kind of patient?
Trauma or flu-like symptoms,
Okay.
pneumonia,
What medical history is usually associated with?
COPD.
COPD, and what happens?
They deteriorate their alveoli cellular
Gosh, this
wall.
table back here is being so quiet, it's making me really uncomfortable.
That's loud.
So, what do you guys think back there on table number 2? Pressure's on. Nothing, anybody?
Does the pressure just build up too much in there?
Okay, so we're gonna say a COPD patient. Okay, so you got a COPD patient. What happens with COPD in their alveoli?
It's damaged.
Okay.
expands it.
Okay, so what? So it loses its elasticity, right? So you put air in, what happens? Does it all come out? All right, so what happens? Put more air in. So what happens if you increase intrathoracic pressure with maybe a coughing attack? It pops, right? So it's gonna pop. So we call this a bleb, right? So it's very common. So they'll start to have shortness of breath after a coughing attack with a history of COPD. So you've now blown a hole in part of your alveoli, right? So intrathoracic pressure is going to change, and it's going to start to collapse the lung, right? So it just starts to wither up into nothing. So at this point, what do?
It's not under pressure, nothing, it sounds like.
Yeah, there's not a whole lot we do. We recognize, and then we continue to monitor for tension pneumothorax. what happens with a tension pneumothorax is as it collapses, you start to get air trapping here, okay? Most of the time, this is going to occur in trauma-related patients if they have some sort of open wound where there is air getting into the thoracic cavity. So as this air builds up, it continues to increase your pressure in there, it keeps opening, keeps shoving this lung farther and farther, and then what's gonna start happening is this air will fill up this side of the chamber, and it'll start pushing on this lung over here. All right, so if you take this lung and this lung's totally collapsed now, and it's shoved over here, what's it gonna look like? So your tracheal is gonna shift, right? Trachea is gonna shift. So when your trachea shifts, we call that tracheal deviation. Okay, now we're starting to think paramedic-wise. We're like, okay, we're smart, we're awesome, we know this, we recognize. So tracheal deviation is actually a fairly late sign of tension pneumothorax. But when we get that tension pneumothorax, we've started to, and this is gonna start to cause cardiac output issues. Why? Right, so this lung and this air and everything is gonna start to keep the heart from getting its full contractions. So as you get that squeezing down on the heart, you're gonna get cardiac output, the patient's gonna start to get really desatted. You're gonna have a couple other additional findings that you could potentially have. You'll have hyperinflation. So would you expect, which side would you expect to be hyperinflated? So you're gonna expect the side with the air, okay? So the air is gonna hyperinflate because it's shoving everything over here. So the pressure's gotten so much here that it's pushing on this. So this side will overinflate first, okay? So you have this overinflation, so you're hyperinflated, you recognize that, now you got this tracheal deviation, you're like, okay, we're to that needle decompression phase. Yeah?
So from a field perspective, if I have a patient that has the potential of a pneumothorax, I don't necessarily need to do anything unless I see an exterior clinical sign of tracheal deviation to know that it's a tension pneumothorax, and then I intervene. I'm trying to think of another field diagnosis that I can have. And
So-
might change.
So you'll get drop in O2 sats,
Yeah.
lowering of your, changes in your end tidal. You can potentially have cardiac output starts dropping. And so all of those are early signs before the late signs of, boom, we've completely shifted over.
Listen to auscultating and lowering the lung also show that, because you're not gonna hear the breathing at that point.
You wouldn't hear it
Like,
for a
as the
collapse.
lung is moving, you're not gonna hear.
Yeah, and so the thing with that is you're not really going to be sitting there like every 2 seconds listening for lung sounds, listening for
Does
it
it collapse
as it
quickly?
as it moves up. It has the potential to move fast. It all just depends on how big the bleb is, right? So a big bleb, and by the time you get there, it could already be into a tension pneumothorax. Versus a small one, it could be like, hey, you notice some diminished lung sounds here. Do COPDers have diminished lung sounds already, probably? Yeah, so a lot of times you'll have a hard time even recognizing that there's a simple pneumo going on. You take them in, and then like a couple hours later, the nurse comes up to you and be like, hey, that patient actually had a simple pneumo going on. Oh, hey, cool, all right. Nothing we're gonna do for it different, right? It's the ability to recognize that you're moving from that simple into the tension, okay? So then when it comes time for that to decompress, you recognize cardiac output's going down, this is getting really crappy, this person's not doing good, now we can do our needle decompression, right? Everybody cool with that? Everybody ready to stick a needle in somebody's chest?
Yes.
Yes. All right, grab a partner. Grab a pen.
Monitor going first.
Grab a pen, you're gonna need it. Here we go. Needle decompressions. So, let's see, I got a, there we go. Okay, landmarks that you are looking for. You have your sternal notch. So everybody find your partner's sternal notch. Doesn't do you any good to find it on yourself, because you are not gonna be needle decompressing yourself. Find your sternal notch. All right, so we have our sternal notch. Okay, find our clavicle. Clavicle to sternal notch. Okay, you can find your manubrium.
Not sternum.
Just below your manubrium, you'll find a little ridge. There's a little ridge on the sternum there, right at the very top of the sternum. So clavicle to the flat part is your manubrium, down to your ankle of Louis. Okay, once you hit that ankle of Louis, take that finger, slide it either left or right. Okay, you will find a little soft spot there. That should be your second intercostal space, or sorry, your first intercostal space. Now, slide down one rib. Okay? So you're gonna go down one rib, slide that out to the mid-clavicular line. Oh, are we finally there? Because I hope you guys are, because right now is when you gotta do a needle decompression. You gotta stick a needle in their chest right here, right now. Okay? So mid-clavicular line, just above the third rib. So you're gonna find that third rib, you're gonna go up and over that third rib, and that's where we're gonna stick the needle. We're gonna glance off the top of the third rib. Piece of cake, right? How many people are willing to do that right now? The cool thing is we'll practice with that. We'll practice with that on our dummies in the lab, so you guys can actually stick the needles to see kind of what it's like to do that.
The intercostal.
Everybody good? All right, grab a different partner, find it. You have 5 seconds. 5 seconds to find it on another person. Go. 5, 4, 3, hurry. Find it. Stick the needle.
Right there. Right there. Right there.
Right there.
Wait, this is the top?
Hurry up. Stick the needle. They're struggling.
Wait, is this that far? Oh.
You're dying.
Right here, so I can put it. Hopefully you don't die. I can't feel the rib though. I only feel, oh, okay, so clavicle.
That is find that spot.
Like right here?
Yeah, it's like
Yeah, that's just hard. What if I'm like so, like, people are so
But when you're dead, you're not gonna worry about pushing yourself.
Yeah, true.
Or not dead, but. Well, I thought I did, but I found it. I did the other side.
I can feel the ribs down here.
So I thought it was hard.
And it kind of sticks out, right?
Yeah, so you hit the first, the second.
All right, everybody good? Everybody feel totally confident with sticking the needle in your partner's chest there?
As long as they have a tension pneumothorax.
All right, let's go ahead and take a quick break. Break time. Break time.
Trying to push car without hurting you and like find
See, does it show it in here?
Damn it.
That was like fun at first. I was like, oh,
I don't know what she's saying. Yeah, there's some people like that. She's just decided to take her head and then just randomly. Oh, like, Chris, right here. People probably.
That's probably what you're thinking. Probably.
Ow, my chest.
At the bottom, impaired diffusion across pulmonary membrane. Those patients are what patients?
Is this for me?
Pulmonary pulmonary membrane.
What was the question?
Impaired diffusion across the pulmonary membrane.
COPD.
Keep going.
P.
Nope, keep going. Pulmonary membrane issues. What would cause the membrane to maybe widen, to maybe?
Oh.
Diffusion.
Pus, bronchitis.
How about pulmonary edema? How about,
Yeah.
how about fluid? So your fluid is causing a issue for you, so therefore you have to eliminate some of that fluid, send it out into the interstitial space. This is where we go with our CPAP, our nitro, try and flush out some of that fluid out of the lungs. Okay, so this is our CHF patients. And then at the very bottom here, impaired pulmonary blood flow. What would impair pulmonary blood flow? There we go. So PEs, thrombosis, multiple things like that, okay? We can fix CHF. Can we fix PEs? No. Are they gonna present with shortness of breath? So do we give them NEP treatment?
Won't help.
It's not gonna help, right? So this is where we don't just start throwing treatment at people because they're short of breath. It's the recognition of, oh, hey, we got into your history, you're having a hard time breathing, you're statin, can be high, can be low. Those can go either way with PEs. But some of the stuff is acute onset. Like, boom, I'm sitting here and all of a sudden, boom, I can't breathe. It's like, that's not a normal presentation. Most normal presentations are, I've just been working for the last couple hours, it just keeps getting worse, keeps getting worse, keeps getting worse, kind of like when you have the flu, it's like you start off feeling, and then it just keeps getting worse and worse. So with PEs or thrombosis, it's kind of usually an instantaneous onset. So those are one of those things that red flags can go up. Now, can it be a slow onset? Absolutely. But majority of the time, these are gonna be the red flags that, boom, happen instantly. I'm sure, yeah.
Would that be clear lung sounds and no restriction with ventilation or with respiration?
Yeah, so there's very little presentation like that is going to tell you this person is having a PE, right? So more likely they are gonna have clear lung sounds because of the fact of their lungs are fine, right? It's not getting the blood flow that they need to cause this. So you start blocking off blood flow to the lungs, what are some of the signs and symptoms that you're gonna present with? How's the heart gonna initially respond? It's gonna pump faster, so you can get tachycardia patients, right? So then is the presentation of tachycardia, is that normal for somebody that's already having a hard time breathing? Yeah, because they're anxious, right? So now you're like, what's it gonna be? What's the presentation? So, majority of these have something in their history. They have a history of blood clots in their legs. They have a history of travels. They have a history of bedriddenness, okay? When I was on probation, I had Dr. Doherty. She was our physician advisor. Scary, scary person when you first meet her. So she was right. She rode along with me. Like, I did everything in my power to dodge her for the entire, we went on a call first thing in the morning. We're like, oh, she's not here, yay! Because she was on the roster. I'm just like, oh, so I jump calls all day long. I'm just like, oh, we can't make it back to the station. Well, finally, all of a sudden, the engine shows up because they didn't want her at the station anymore. They're like, oh, boom, let's get her on the ambulance. So I'm on probation. She hops in the back of the ambulance. She's like, hey, Chris, this is what we're doing. Oh, okay. Yep, nope, yep.
Wake up, wake up, it's time for class.
This for you, Mark.
This is my alarm clock from last night to do homework, but I set it for PM.
Oh.
I'll figure out how to turn it off in a second. So. It's good.
All right, I think we're good now. So she bails in and she's like, hey, how's it going? I was like, oh, great, awesome. I get to get watched by my physician advisor. It's not usually something that's really ideal that you really want to do, right? Feel like you're gonna do everything wrong. So what do we get? We get very first call of the day. Like, we walk into this house, this gal is, can't breathe, one word sentences, gasping for air. And I'm like, oh, geez, of course. Dr. Doherty's standing right here. So I was able to ask 3 questions. I go, when did this start? Have you ever had this before? And what do they do for you? So when did this start? It started 15 minutes ago and I called. Have you ever had this before? Yes. What do they do for you? They had to put me on blood thinning medication. So I get those 3 questions out of my mouth. I get lung sounds are clear, SATs are 98%, but she's obviously in respiratory stress. Dr. Doherty standing there, she goes, okay, Chris, what's wrong with this person? I'm like, pulmonary embolism. She's like, all right, cool, what are we gonna do for it? I'm like, O2 IV, monitor, rapid transport. And she's like, okay. And so I'm just like, oh, whew, dodge that one. I'm hooking up to the back of to the 12 lead, and she's like, before I can even get anything hooked up, she goes, what's the most common arrhythmia in PEs?
Ooh.
Once again, I'm like, because you can't think straight when somebody's like drilling you like that, and it's a stressful call. I'm like, sinus tachycardia. She's like, okay, good, what do we do for it? I'm like, nothing. Supportive care, O2 IV monitor, continuous monitor, we gotta get into the hospital. She's like, good, let's do it. I was like, okay, whew. Time to go to the hospital and come back. And like, I'm typing my chart, she climbs up in the ambulance, she goes, so, how do you think that went? I was like, good? She's like, yeah, I thought you did a really good job. And it's like, so you got some history under your belt, you act like you've done this before. I was like, yeah, absolutely. She didn't ask me another question the entire shift. She just let me do my own thing, right? She let me run calls, but it was her way of checking on us and ensuring that we're doing what we're supposed to be doing. So one of my fellow probationers got her to ride on the next shift. She asked questions on every single call for the entire shift. It was my worst nightmare. She would not stop. She actually had to take over a call from me because I got so nervous I couldn't make decisions. I was like, whew, thank goodness that wasn't me. But based on just her presentation and knowing what types of questions to ask, luckily I asked the right 3 questions this time, just based on presentation, that I got her history immediately. And like I said, history will tell you virtually everything you need to know about these patients, okay? All right, so we got a bunch of stuff, so we only got an hour, so we're gonna breeze through some of this stuff to get to some of the advanced airway management stuff. Lots of tidal volume stuff, forced air percentage, let's go, respiratory distress. We all know what types of things can cause respiratory distress. Orthopnea, we all know what orthopnea is.
Straight up.
Close, not quite. Just the opposite of straight up.
Something.
So, they lay down, they get short of breath. So when they lay down and they get short of breath, what does that tell you? They're fine sitting upright. But as soon as they lay down,
Mucus, fluid.
yeah, fluid, there's some sort of fluid. CHF, pneumonia, something like that. Big time findings for you, okay? They're like, hey, how have you been sleeping the last couple days? I've had to sleep in the recliner. Okay, you have a fever? Okay, yes, no, okay. What kind of history, what kind of meds you on? Okay, CHF versus pneumonia. Tripod position, we all know that. Nervous system impairment, right? So that's kind of like your quads and your paraplegic patients that don't have real good accessory muscle use as they're breathing. And lower and upper airway obstruction, obviously. Okay, we've got those. Barrel chested, what types of patients?
Pediatric.
Oh, I hear a lot of
CO2.
2, 3, 4, 5. What do we got? COPD, yes. Why is it?
Get their,
Trapping, right? So the air keeps getting trapped, keeps getting trapped, keeps getting trapped, they get used to it. Okay, the body gets used to it and it continues to have like there's always a little bit of trap. Paradoxical motion is opposite of what it should be doing, right? Right? So flailed segments is where we get these. All right, so you take a deep breath, it goes in, let it out, pushes out, that kind of thing. Opposite of what everything else is doing. Personal breathing, what are they trying to create?
Native push.
Their own what? Right? They're trying to create their own intrathoracic pressure, maintain, keeping those alveoli open. They're creating their own peak, right? Their own CPAP. They're trying to create it. They're trying to keep that pressure going. Okay? Crepit. Subcutaneous emphysema. Let's go with that one. Subcu. This is going to be a huge one for paramedics.
Bubbly under the skin.
Rice Krispies, right? So imagine taking Rice Krispies, putting it in a Ziploc bag. Okay, so you got a Ziploc bag with Rice Krispies in there. Lay that on the table, and you push on it. You don't listen to the plastic part of it, but you listen to the Rice Krispies underneath there. So that is going to be usually in the chest wall area, traumatic in nature most of the time, or a COPD bleb, but they're getting air trapping underneath the skin in the subcutaneous tissue. This is a common sign of a tension pneumothorax. So this is one of those things that you're going to look for. It's super cool when you actually find one and you're like, is it actually popping the bubbles or is it just kind of moving them around in there? So you want to be a little careful as you're pushing air around under the skin. So I've seen people put a king tube in someone, right? Everything's fine and dandy. By the time they get to the hospital, the whole side of the face is all swollen, the side of the neck is swollen. What do you think happened? They're inflating their face, yes.
Overinflate the lungs.
Does anybody know Zach, Harney from last year?
Uh-huh.
Yeah.
if you guys have contact with him, I think he might have sent it to me. So his dad had a pretty crazy video happen where he fell, jumped, or fell through, hit his chest. 2 days later, his whole face and everything swollen, subacute emphysema, this entire thing. You know, basically walked himself to the ER, kind of a crazy thing. But it's pretty cool before, after, it shows the event and everything. We were talking about it one day, he's like, hey, can I show you something? That's a pretty cool video. So if you guys have, he may have sent it to me, I'll have to go back and look at it. Crepitation, we don't know what that is, right?
Why was the face swollen?
Because the air, so the air just continues to swell up. So with the king
So
tube,
was
it
this-
actually, so as it went in, they caused trauma in the side of the tissue area.
Of the esophagus?
Yes. No, it was more of a posterior back of the throat area.
Into the facial tissues?
Yes, and so it started filling up the neck, and then it ended up filling up the side of the face, and like, so they had this massive, like, it looked like an allergic reaction that had occurred.
So like as the distal portion of the king went through, it caused damage in
Yes.
the cuff above and below the trachea, sealed it off,
Yep.
and then that positive pressure not only went in the
Inflated
trachea,
the
but it
tissue.
also
Yep,
inflated the tissue.
inflated the tissue, exactly, because you know you come in sideways.
Right.
And then, so they had some sort of, they had one of the contraindications of king stuff, esophageal disease. So they had the thinning of the.
Esophageal lining.
Yep, and so, yeah, it was nasty. It was very, very nasty. Crepitation, what kind of patients?
Bones maybe.
Snap, crackle, pop, right? Most of the time, like, you'll get that thing where like, you'll say, hey, take a deep breath, and you know, this feels, you're like, oh, that's gotta hurt, right? You're gonna get that little cringe in you. That's like, and they're like, hey, did that hurt? They're like, nope, not at all. I'm like, oh.
Hurt me.
I'm like, you have something going on in there. I don't know what. So what's the first question out of my mouth? They say, no, it didn't hurt.
Are you on drugs?
What if you had?
That would be a good one if you're on pain meds. But my next question is like, do you always crack and pop like that, right? So you want to find out if that's normal or not normal. We all know 1 and 2 word sentences, right? It's very obvious when it happens. I wanted to bring this up real quick. So we talked about mid-clavicular line. We also have mid-axillary line. This is important because we also do needle decompressions on the side over here. Okay? So we do it in the fourth or fifth intercostal space, anterior axillary line. Anterior axillary, so the front aspect. So basically take somebody, slice them right down the middle, take your hand, go like that, basically like that, finger there, anterior posterior line, okay? Take your thumb, just like that, okay? So we can do that there. The only time we'd really ever do that is if there's major trauma to our primary site that we're going to use. And when we grab the dummies and we start practicing this stuff, we'll work on finding it and that kind of stuff, all right? The other reason these are important is when you're describing where wounds are located, like if there's holes, punctures, anything like that. So if somebody's got a entrance wound here and an exit wound here, how are you going to describe that?
Right mid-clavicular to left mid-clavicular.
All right, do we describe them as entrance and exit wounds?
No.
Are you guys ballistic experts?
Holes.
Are they a puncture wound?
Yeah.
Yes. So you have a puncture wound. So one thing you never ever want to do is you never ever want to differentiate between an entrance and an exit wound or a gunshot wound versus something else. You have a puncture wound, you have a hole, you have something that you don't want to put that, because what's going to happen is you're going to go up on the stand and be like, oh, so, you are the expert here now, we're calling you and talking to you, so this is the entrance, this is the exit, so therefore my client couldn't have done it because he was standing over here on this side. And you're like, well, that's just what the cop told me that that's where it was. So it's always just puncture wounds, these locations, very vague when it comes to making those determinations. All right, airway compromise, snoring, gurgling, stridor, wheezing, crackles, and ronchi. Whew. What do these tell you? Snoring means what? Means what?
Upper airway.
What part of the thing is occluded? What's happening?
Tongue.
Tongue, right? Tongue. Gurgling.
Fluid in the
Upper or lower airway?
Upper.
Can it be the bottom too?
No.
Can they be completely full? But where you're going to hear it, upper airway, right? Well, how do we deal with this?
Suction.
Suction. Stridor. Good or bad? How bad? Of all these, Strider's the worst, just so you know. So trying to bad, high pitch, upper airway obstruction, not good. Okay, wheezing, upper or lower? Okay. Crackles? Does everybody know what crackles are?
Fluid in the base.
Fluid in the lungs. Everybody know what that sounds like? So if you take your hair, rub your hair together, hear that little crackling sound? Okay, that is fine crackles. Congestive heart failure is the presentation for that. So, fluid in the lungs. Can rhonchi also sound like fluid in the lungs? So this is where, once again, your history is going to help you make the determination whether or not this is pneumonia fluid, bronchitis fluid, or congestive heart failure fluid, okay? So these commonly get flipped back and forth because people are like, dude, this person's so full, like they're overflowing, they're congestive heart failure, and they'll call it bronchi. You can just call it coarse crackles, okay? Because the crackles really differentiate between the congestive heart failure and the infection approach, okay? So the bronchi is more of a, you say somebody's got severe bronchi, that's going to be more of a, okay, they got pneumonia, bronchitis, something along those lines. Does that make sense? Okay. All right, Brady, tachy, hyper, we all know these, right? Airway trapping, we've covered that. Shane-Stokes respirations. Oh man, good or bad?
Yeah.
Most commonly seen in what kind of patients? Brainstem injuries, okay? So these are your Cushing's, this is one of your Cushing's triad presentations for increased ICP. Somebody describe Cushing's, or Shane-Stokes for me.
It's short, shallow. It's a big, wide, and then it decreases. Kind of like that picture.
Oh, we got a picture right there, right? So yeah, so you're gonna go through periods where you're really, really fast, very rhythmic, and then whoop, you're down to almost agonal to ataxic respirations, and then immediately back to rapid respirations, and then ataxic, all over the place, agonal respirations. And so you're really gonna get this Torsades style presentation of breathing. Really, really bad. It's an ICP most commonly, so you really just got to pay close attention to that.
You said, it says up there drugs.
Drugs also can cause that as well.
What drugs are we looking at?
So any sort of stimulant-related, neurological affecting. So like sometimes if we give ketamine to patients, you can send them into a Shane-Stokes type respirations prior to them having full-on respiratory depression. So they can just be like, you'll give them the meds and then all of a sudden they'll just start going, and then they'll go into this weird phase and then you think that they're going out and then all of a sudden, boom, they're back again and then they're totally out after that. And so just different types of neurological affecting meds.
And that's when we give ketamine before intubation. Hopefully not for just sedation.
No, it's mainly for the sedation portion.
I just mean like a sedation of a combative patient.
You wouldn't want it to go that far.
What is the question?
Just different dosing. Is it too much or just with ketamine? Or higher end of the dose?
For
Ketamine for the Shane-Stokes respirations.
So it just doesn't really matter. So you just different people will have different reactions to it.
Okay.
Some people, boom, they'll just go right out. Other people will have the Shane-Stokes type. And all of these that are related to drugs, that have drug relations, it's not every single time this drug is going to cause this for this person. A lot of them are dependent on individual patient presentation, what additional things they have. Kussmaul respirations.
Big
This is a
facts.
paramedic skill. Oh yeah, you don't want to screw this one up. You're gonna get RSI taken away for the entire department if you screw this one up.
We're breathing off ketones.
Okay, good. So this is your diabetic DKA patients.
It's gonna smell fruity.
Okay. Sick or not sick?
Sick, very sick.
Very sick. So, Kussmaul respirations are very rhythmic, rapid respirations, right? That is very normal. Looks like VTAC, okay? Very rapid, very deep. Some of these patients become unconscious. Decreased LOC, you want to RSI them. okay? Because you feel like they're not able to control their own airway. What are you gonna do when you take over their airway?
At a quicker rate,
How are you gonna bag them?
not one every 5 to 6 seconds. A little faster?
Okay. So is their body attempting to do something already?
Yes.
They are trying to regulate, right? So what happens if you RSI somebody and you take away that regulation?
In there.
Even more acidotic.
It's gonna make it worse. So, long story short, we used to be able to medically RSI people. And then we had a paramedic, RSI a Kussmaul DKA patient. What did they do? They slowed down the respiratory bagging. What did they do then?
More PA and more
They
acid.
did this to the patient. Guess who the receiving doctor was? Dr. Doherty. You know how Dr. Doherty came into the room, walked in, like, hey, just want to let you guys know, you single-handedly killed that person. Have a nice night. I walked out. Yeah, that's the kind of thing, like, we're gonna make decisions like that as paramedics. Do you think that was the best way to handle it? Probably not. Do you think she was mad because she's our physician advisor and we screwed up? Absolutely. Could she have handled it better? Absolutely. But shortly thereafter, now we have to call. We now have to call for medical RSI because of this case. Had it been any other doctor, we probably would have been free and clear and, you know, had a little coaching session, but she was so fired up over it. Now it's like, hey, you gotta call in, right? So you have to recognize when you have an irregular respiratory pattern, what's going on, and is it something that the body is attempting to compensate for? Is it trying to fix something? And if so, you can't eliminate the body's ability to fix it, right? So you're gonna continue to back this person fast. Continue, continue, continue. All right, central neurogenic hyperventilation. Whew, I love just saying that, it's just a cool word. How does that present? Without looking at your book, Justin. Anyway, nobody knows central neurogenic hyperventilation?
No.
Nobody can even pronounce it. Jeez. It presents like this. Exactly like that. Exactly like Kussmaul's. So now you guys are awesome at your history taking because we've really ingrained that in your head. So what do we find out? Oh, there's some sort of traumatic event. Okay? This is a non-reversible thing. Okay? We can't fix this. Something traumatic happened in the brain, causing an increase in ICP. This is not the, oh, hey, this person's Kussmaul's respirations, let's check their blood sugar, let's do this. It's like, no, there's something, maybe a stroke, maybe they fell, maybe they've got a bleed going on. But this is something that we are gonna have to continue that respiratory pattern because it's making an attempt to compensate for something, right? So we continue to monitor our oxygen level and our end tidal, but is this something that we could potentially slow down with? We can slow our breathing if we are a sinus patient.
There's no metabolic reason for it.
Yes. So this is the difference between your Kussmaul's and your central neurogenic. So Kussmaul's is a metabolic issue that's going on. This is a traumatic event that because of the ICP, you're getting neurological stimulation that is causing this respiratory pattern. Okay? So it's okay to slow down here, but we're going to use our tools of our O2 sats and our end tidal to continue to monitor and keep this person in the right range. Make sense? Whereas Kussmaul's, we gotta keep them going. Agonal.
There's one breath every
Sick.
10
Good.
seconds.
Good.
Not much time.
Look, something like that. Couple times a minute. Do we pronounce people dead with agonal respirations?
No.
Yes.
Yes.
Scary. We do it. Okay? So you have different phases of agonal respirations. You have agonal respirations where they are actually taking lung capacity. Okay? They're taking that breath. There's actually air going in. And then you have agonal respirations that looks like this. There's no lung function. There's no air moving, right? So those are the patients that we actually, they're super nerve-wracking to do. But you pronounce them dead. It's like they've been asystole for 30 minutes, but yet they have this crazy respiratory drive that's still going.
It's kind of like a mammalian reflex.
I couldn't tell you what the cause of it is. One thing you don't want to ever do is you don't want them waking up in the morgue. Like, I kid you not, like, these are the ones that terrify me where I'm just like, dude, I've been doing this for 19 years, thank God no one's ever woke up. But like, I had one call where they're just like, the cops were there doing their investigation and the family was like, oh, he's breathing. And like And he's just like, the cop looks over, he's like, it looked like he was doing that thing, and he's just like, so they called us back. And we're just like, oh yeah, it's a normal thing, the body goes through, da. And I was like, oh, please just don't get faster. Please don't get faster, right? And so those are the ones where it's just like, you gotta know you gave a whole bunch of meds, right? You gave a whole bunch of epi, you gave all these medications, and then there will be times where it's like, and these, when they get to that point where they're just like, it's maybe 1 a minute. Okay, so it's something that's just, it's non-existent, except all of a sudden, boom, there it is. All right?
Isn't that something where you would CYA and
Oh, absolutely.
transport them and?
Not necessarily, because we don't transport unless we have a pulse now. And so, if you have your end title's below 10, you've been there for more than 20 minutes, you talk to the doctor and you explain, because that is a normal patient occurrence for these adenoid respirations. And so it's something, that's how you're CYA, you're covered, you're talking to the doc, you're explaining, he was like, hey, this is what we got, this is what we've been doing, end title's this, we've been asystole the entire time. And so that's kind of how you CYA there. So, but if there's air movement, yeah, you just keep working it. You keep working it, because a lot of times that air movement will increase, respiratory rate increases. Next thing you know, they're bucking your tube, and you're just like, oh, hey, we're actually getting something here. So.
Can we go back to the difference between DKA and central neurogenic hyperventilation?
Yeah.
Just as far as our history taking?
Yeah. So this, they're going to present. So you're going to, it's more likely they're going to be unconscious, unresponsive type of a patient, okay? Because they're breathing so fast, it's going to be unsustainable for them, and so their body's going to just start to shut down. So with your